Greetings, everybody. And I should say sunny greetings from Zambia. My name is Yudi Soko. I'm your moderator for today. A warm welcome to our fourth session. And our theme is integration of survivorship at the policy level in Africa. When I decided to volunteer for this session, to moderate this session, I thought, being a cancer survivor, it would be relatively easy to moderate. Thought the subject matter, something I'm well familiar with because I am a 2 times cancer survivor. But little did I know that this subject is more complex than I had anticipated. Why do I say so? I was diagnosed with cancer twice. The first time when I was 23, and the second time when I was 49. And the dynamics between being diagnosed when you are a young adult and being diagnosed as an older person are very, very different. Not only that, depending whom you ask, there are various definitions of what survivorship is. Some say it's from the moment you are diagnosed. Others say it's from the moment you leave active treatment and then you become a survivor. I can tell you in Zambia, many patients do not consider themselves survivors until they finish active treatment. And we do not have a national definition for cancer survivorship. So therein lies a lot of unanswered questions. And I look forward to delving into this theme with the panelists and with you, the rest of the members of the meeting. Mishka, I have lost the agenda I'm trying to go through. Can you please bring it onto the screen?
I believe that was Charles that was helping with that.
Regarding the theme. Thank you. Right. Now, some admin issues. Reminders, please. Please mute your microphone if you're not speaking. If your bandwidth permits, please turn on your video. It helps make our sessions more interactive and very rich. You are free to use the chat at any time to introduce yourself, ask questions, or make comments. Enable subtitles on your screen as needed. What are the objectives of our meeting today? Our meeting literally 1 week or so before Christmas. Number one, to discuss current efforts in survivorship. To discuss current efforts in survivorship in the African region from a personal, community, clinical, research, and policy perspective. Number two, to outline the importance of defining and deliberately incorporating survivorship in policy and practice, development and implementation. Number three, to deliberate on ways to ensure that ministries of health work and incorporate inputs of all stakeholders as they integrate survivorship into their national cancer control plans. Before, thank you. Speakers and bios, thanks, Mishka. Who am I? Well, as I have mentioned earlier, I am Yudi Soko. What I did mention is that I'm the founder and executive director of the Zambian Cancer Society. And I'm also a 2 times cancer survivor. We can go down, Mishka. Is Miriam in the house?
No, not yet.
Not yet. Okay, we can go down. We have a number of speakers, panelists, and I will be assisted by a number of eminent speakers. These include Ms. Elise Garton. Elise is a health specialist at the U.S. National Cancer Institute Center for Global Health, where she works on data and evaluation related to NCI's global cancer research and training portfolio. She joined that institute in 2020 and works in electronic health records implementation in the United States and Middle East. She also has a master's degree in global health research at, oh, Elise, I can't pronounce the name of that university, but I know it's in Amsterdam. All right. Thank you, Mishka. Joining the panel is Mr. Isaiah Gitonga. And I'll just summarize it a little bit. I have it here. Right. Isaiah is a doctoral researcher in the Department of Psychology and the Assistant Living and Learning Institute based in Ireland. His current research seeks to explore the role of connected health in cancer survivorship. Isaiah is a member of the Survivorship SIG at the IPOS and is currently involved in a global review of the NCCPs to determine the extent to which survivorship and psycho-oncology care and services are represented in the NCCPs and NCDs. He's also involved in the ongoing review of survivorship care in Africa and other survivorship projects. Previously, Isaiah worked as a researcher and coordinator for several community-based mental health programs in Kenya. And we have as well Mr. Moses Echodu. Moses is a childhood cancer survivor from Kampala, Uganda. He is 30 years of age and currently volunteering with Uganda Child Cancer Foundation as the program director. As a child, he suffered from Burkitt's lymphoma. Moses has a bachelor's degree in information technology. He has spent many years or several years involved in cancer awareness among young people, advocacy, and leadership. He is actively engaged in creating cancer awareness and advocating for policies to improve access to cancer services for young people. Right. And then finally, last but not least, we have my sister, Gertrude Nakibude. Gertrude defeated breast cancer 21 years ago, a co-founder and chief executive officer of the Ugandan Women's Cancer Support Organization. Over the past 20 years, Gertrude has been developing cancer advocacy and awareness campaigns. She has participated in several breast health guidelines supported by University of Washington. And some of these include the development of the Breast Health Global Initiatives. Gertrude has also participated and graduated in scientist survivor programs run by the American Association for Cancer Research, a program that jump-started her advocacy and devotion to create a better understanding of cancer in Uganda and the rest of the world, if I may say so, and make cancer treatment affordable, timely, and of high quality for all cancer patients. Special warm welcome to my panelists. Mishka, I'm assuming that Dr. Miriam is not yet with us.
She says she is logging in. So as she does that, you can go ahead and proceed, and I'll send you a message once she's on.
Okay. If you could kindly go back to the agenda, Mishka, that would help me.
Actually, that's Charles who is helping us. So thank you, Charles.
Oh, it's Charles? Oh, okay. Thank you very much. The way we're going to run our meeting today is a bit different from what has been done previously for those who have participated before. Each of the panelists will have 5 minutes to give a brief of what it is that they're involved in. And then after they all give their presentations, then we shall open the floor or the meeting to a panel discussion, and we'll have 55 minutes for it. So without further ado, I'll ask Elise to start off. Elise, are you ready?
Sure.
All right. Over to you, Elise.
Thank
Thank
you.
you.
Yeah. Hi, everyone. My name is Elise Garten. I'm at the Center for Global Health at the National Cancer Institute, with apologies for the Dutch pronunciation of my alma mater. So I'll just share a little bit about the work that I've been doing related to survivorship. And then hopefully Miriam will log on and we'll continue with the panel. So over the last year and a half or so, I guess, I've actually been leading a group of researchers from the US, Europe, and Africa, analyzing national cancer control plans of African countries to see whether and how they included objectives and indicators related to survivorship. And we did this actually as one of the contextual data sources for a 360-degree situational analysis of survivorship in the region that I think others will speak about today too. But also just more broadly, sort of the basis for this is the knowledge that these national cancer control plans, or NCCPs, are critical for countries to address their cancer burden because they help outline priorities. And survivorship is increasingly relevant globally, but especially in Africa as people are aging and cancer diagnosis and treatment services become better, we have more cancer survivors. And so this analysis was actually built off the work of two other papers. And so if you're interested in this topic, I really recommend these. There's a 2018 global review of NCCPs that was led by the Union for International Cancer Control that looked at all types of different topics in these plans. And then a 2020 analysis of survivorship content in the plans of US states. So we took some things from both of those papers, borrowed some methodology, and then reviewed 21 current or recently expired NCCPs in Africa, extracted all of the survivorship related strategies in them, and then coded them. And we coded them based on 11 domains that are in these sort of National Academy of Medicine recommendations for survivorship care. And these are sort of seen as like the really sort of the basis of what should be included in survivorship. And so we turned those into codes that we then attached to all these survivorship strategies and counted them up and saw sort of what was in each plan. And so the good news is that all of these plans had at least one survivorship related strategy. So survivorship was included to some extent in all of these plans. The not as good news is that none of the plans covered all 11 of those domains. So I think the most was 7, and most plans had 4 or 6 domains. So there's some survivorship content here, but it's not necessarily spanning all of the areas that would be needed for a comprehensive survivorship care plan. And I can go into more detail later about sort of what these domains are. I think 2 other key points that we found was that over 60% of the survivorship strategies in the plans were specific to the context of palliative care. And so we know that palliative care is really important, but survivorship is much greater than palliative care. And so one of the things that we're hoping is that in the future, these plans would sort of extend their survivorship related strategies beyond palliative care. And then another interesting point was that 40% of the strategies also included a measurable indicator. And those indicators are really important to actually measure progress and monitor the translation of policy to practice. So without the indicator, it's hard to know if we're actually achieving what we set out to do in the NCCP. So that's another area of improvement for some of these plans, is to make sure that they have ways to measure their strategies. So the idea behind this is that what we found in this analysis can help policymakers and also authors of many of these plans include more concrete and comprehensive survivorship care priorities, and increase awareness of survivorship among clinicians and survivors themselves. So again, I can go into some more detail later on in sort of what these domains are, but I think excitingly, this has just been accepted into the Journal of Cancer Survivorship. So we'll also share the manuscript once it's published next year. And then I think in a hopefully even more practical way, for each of these 21 countries, we're going to creating survivorship profiles that will live on the ICCP portal alongside their National Cancer Control Plan. And that will sort of show in like a easier to digest format and some visualizations about what aspects of survivorship are included in each of these plans and how they stack up against other countries. So a couple of exciting ways to share this information. coming ahead in 2023. All right, and that sort of wraps up what I have to share. It looks like Miriam is on, so maybe I'll pass it on to her.
Hello.
Thank you. Oh, hi. Thank you very much, Elise. Dr. Miriam, welcome to our meeting today. As you settle down, let me use this opportunity to briefly read your bio.
Oh, sure.
Sure, you're right. Dr. Miriam Mutebi is a breast surgical oncologist and assistant professor in the Department of Surgery at the Aga Khan University Hospital in Nairobi. She is also the Vice President of East Africa of the African Organization for Research and Training in Cancer, IORTIC. She's the treasurer for the Kenya Society of Hematology and Oncology, KESHO. Dr. Miriam also sits on the board of directors of the Union for International Cancer Control and is a co-founder of the Pan-African Women's Association of Surgeons. Dr. Miriam has done several fellowships in breast surgical oncology in South Africa and in the United States. She also has a master's degree in clinical epidemiology and health systems research. Dr. Miriam is an avid supporter for the education and support for women, especially in surgery. And last but not least, she is currently pursuing a pilot's license in order to extend breast cancer services to marginalized areas. Good for you, Dr. Miriam. So at this juncture, Dr. Miriam, Elise spoke first. So if you're ready, I would like to hand over the floor to you.
Yeah.
Thank you, Dr. Miriam.
Thanks so much, Udi. I greatly appreciate that very kind introduction. Can you hear me okay? Okay.
Yes.
Thanks so much. Some of the positions may have changed from my previous bio in the different organizations, but that's neither here nor there. For purposes of this discussion, it was really just to share some of the work and efforts we've been doing around cancer survivorship. And perhaps one of the areas that Elise has really highlighted is the need for survivorship as part of a critical of the care continuum, and really looking at, sort of teasing out that distinction between palliative. I mean, there's a bit of overlap, but really looking at what are the core issues on the ground. As a background to this, one of the areas that we had tried to look at initially is really looking at what is our survivorship program. What we do know is that especially on the continent, in many parts of sub-Saharan Africa, not only are our patients, tend to be 10 to 15 years, tend to be diagnosed, for instance, in breast 10 to 15 years younger than their counterparts in the West. For instance, in Kenya, our average age of diagnosis for breast cancer patients is between 40 to 55, but with a significant percentage of those patients being less than 40 years and about 10% being in their 20s. So really calling into question, and again, I would say testament to the increasing efforts around advocacy. Of course, the majority of patients still get diagnosed with advanced disease, but I would say due to really strong grassroots initiative, we're starting to see changes around that. Now, what used to happen initially was people would, again, it's a bit of a hangover from a paternalistic approach to care, where we would sort of come down from the mountain and tell you what needed to happen. And the focus was really on curing your cancer. But then recognizing now, due to our shifting demographics, our younger populations, we're then saying, okay, you've survived your cancer, but have we made, I think it was somebody who, Lord Hutchinson, who said one of those clinical books, from making the treatment not worse than the disease. And so in taking our patients through the care continuum, it's really looking at younger patients. Are we addressing, concerns around post care, whether it's neuropathies from chemotherapy? Are we looking at the psychological implications of the treatments that we have? Breast surgical cancers have the highest fallout, and indeed in many parts of Africa we find that telling somebody they need a mastectomy sometimes actually results in patients dropping out of the system, just because of, again, the social cultural implications of some of these procedures, having radiotherapy. So really looking at the experience of patients, and once they're through the treatments, what are the concerns around fertility? What are the concerns around sexuality? Because these are some of the areas that as clinicians, we don't feel entirely comfortable to start to discuss. And I was talking to my gynae oncology colleague, and she had a really sort of heartbreaking story where she said she had a lady who came in for a second opinion who had cervical cancer, had a radical hysterectomy, and was coming in for a second opinion because she's been trying with her spouse to conceive for the last 6 months unsuccessfully. And so that just shows us there are gaps really all the way in the processes. And so it's really looking at how do we how do we develop a holistic approach to our patients, and how do we ensure that they're supported through their journey, whether it's from a psychosocial aspect, whether it's from a financial aspect, that does also will have psychological implications. And so in thinking about that, we try to say, well, what do we actually know about survivorship in our region? And we recognize there was a gap. And so part of the initial efforts that we had done was through the NCCN harmonized guidelines, and really trying to look at how do we sort of tailor this to the patient narrative in sub-Saharan Africa. And so going through that process with colleagues in the African Cancer Coalition across sub-Saharan Africa, we then realized that, yes, these guidelines are great, but how do they actually reflect the lived reality for our patients? And so the next step was part of the work that we're doing now is trying to look at how do we create policies or guidelines that are robust and actually reflect the lived experience of patients. So part of this was doing a almost 360 analysis or situational analysis of what we do know about survivorship in our context and what that actually means for patients. And so the first steps of this are, we can sort of talk until the cows come home, but until we engage with people who are actually going through the process, then it's very difficult to say this is one way or another the experience. And so part of the initial part of the 360 analysis is looking at patients who've 1 year out their cancer diagnosis, looking at what their different experiences are, and then cataloging those to develop what would be the concerns. And the questions are simple around what has your experience been? What would you like more of? And how can we then, build these into actual actionable items? And so that's the first phase. And then the idea would be to subsequently take this data, present it to clinicians who are sometimes frequently the gatekeepers to care, but sometimes the roadblocks to patients accessing survivorship services, and then saying, okay, this is what patients think, what do you think? And then using that to co-create and develop policies that actually reflect good survivorship care in sub-Saharan Africa. So I'll stop there. Like, that was just to give you a soundbite of what we're trying to do, but looking forward to discussing a little more about the logistics of that going forward. Thank you.
Thank you very much, Dr. Miriam. Our third speaker is Mr. Isaiah Gitonga. Isaiah, over to you.
Thank you very much. Just confirming that you can hear me. Perfect. So thank you very much, Udi, for the introduction, but also for the invitation to be part of this great speakers today. For me, it will be more of learning other than really talking, because I appreciate, like, it's a pleasure to have people like Miriam here who doing great work in cancer survivorship, basically in cancer space in Kenya. And I've just recently been trying to follow, some of our work, and I'm really, really excited about that kind of work. So I'll give you a bit of a story about, my involvement in cancer research. So I worked briefly as a nurse in Kenya a few years back, and while I was working there, I happened to work with some patients who, were undergoing treatment for cancer. And at the time, I think cancer was still a bit of stigmatized in our context then, because even saying that you have a cancer was tantamount to, a death sentence. And the gap in terms of psychosocial care for those patients was so huge. As a matter of fact, when we conducted a bit of a study as part of my, my master's work there, was to look at what supports are there to, to these cancer patients apart from, the treatment they get. And we conducted a study to try and see the impact of social support, just social support, which is basically support from family, support from the significant other, from friends. And we found that patients who reported to, receive any bit of support, whether from their significant other, from their relatives, from, their friends, had better adherence to treatment, and also reported to be more, using different measures like quality of life measures, they had better quality of life outcomes compared to those that. And that really, made me to think about it in a more globally aspect. Like, we focus so much on symptoms, which is perfectly fine, but then we forget the bigger gap, which is psychosocial care that comes, or that is very important, not only for the treatment, for the cancer diagnosis itself, but also for the treatment that it has on the patient. And that's what now prompted me to, kind of focus on that area a little bit more. And after I finished my work there, now I moved to Ireland, where I currently, live. And when I came here, I kind of continued with that kind of work on, how to support survivorship, specifically, well-being and quality of life. And now I happen to work with Irish Cancer Society here. So I interact with patients who are, in their different cancer treatment journeys. So the whole difference in terms of the needs, in terms of the supports available that I experience when I work with cancer patients in Nairobi or Kenya, and the ones that I, look at daily when I work with, patients from other contexts, is a whole different. And that's why later on, I think we'll talk about the need to contextualize and do a bit of analysis. And I'm glad, like Alice and Miriam mentioned, about 360 analysis, just to try and understand what needs are there and what supports are there and what resources are there to be able to support these patients, because it's all different. So a bit of needs assessment to inform, the priorities. And so that is a bit of what we probably delve into further in the discussion. Apart from that, of course, I'm also involved in, a global review of the national cancer control plans and national non-communicable disease, plans available. And it's more of what Ellis talked about earlier, but we focused at all the, 235 countries. And out of that, and a few countries that had a mention of survivorship or psycho-oncology, and we were focused on survivorship in the post-treatment phase, because that's another issue now. We do not have a consensus or a clear definition of what survivorship is, as Undi earlier mentioned, and that's where we need to start from those basics. So out of all the countries that we looked at, I think 97 countries, only 20% of those countries had a significant detail in terms of objectives for survivorship care. And 52% of them had a brief mention. And when I say brief, they are statements like to improve the quality of life of cancer patients, or to improve just that, without any clear detail in terms of by what or by when or through which resources. And 28% of them are no mention at all. And good chunk of these were coming from LMICs, specifically from where some our countries in sub-Saharan Africa fall. So the 20% that had significant detail in terms of outlining the plans and the goals and measurable outcomes were mostly from high-income countries again, which shows us that we still need to talk more about survivorship. And I'm glad at the point that this discussion is happening. A lot of countries in Africa are in the process of revising their national cancer plans. I'm aware about Kenya. I'm also glad Nigeria is doing that, Botswana, I think, and a few other countries that I probably am not aware of. So it's great that we are having this discussion. It's great that right now we are looking at integrating survivorship in the entire cancer policy plan, because then that enables us to have very clear goals and also to prioritize care and resources. So I'm looking forward to learning or hearing more, but also sharing a bit of this work that we've been doing here in Ireland, but also in Kenya. So thank you very much.
Thank you very much, Isaiah. Our final speaker is Gertrude Nakigude. Gertrude, over to you. Thank you. All right. I beg your pardon. We have Moses Echodu. Sorry, Moses, I skipped you. Gertrude, if you are ready, you could go ahead. Otherwise, Moses, I believe you were ready to speak after Isaiah. So, Gertrude, if you're ready, you can just let us know, or otherwise Moses can take over. Moses, I see you. Are you ready?
If Gertrude is not ready, then I can go ahead.
Yeah,
no problem.
yeah. Okay. All right.
Yeah.
Sorry about that.
No,
Thank
no
you,
worries.
Moses.
Okay. So my name is Moses Echodu. I work with Uganda Child Cancer Foundation, and the oldest civil society organization in Uganda when it comes to cancer-related issues. And we were founded by patients, caretakers, and staff at the Uganda Cancer Institute. So we are in the heart of the Uganda Cancer Institute. That is where we are located. So if you ever visit Uganda, you will be able to find us easily. As a foundation is that we support families that have children. And one of the things that we aim at doing is providing the psychosocial support to the children in the bid to ensure that the children continue with treatment. That is one. Number two, also preparing patient caretakers for the journey that is ahead, because one of the things that we noticed is treatment abandonment. And as a result of the increased treatment abandonment, we have high numbers of children who do not make it or who do not survive, not because there is no care, but because things like transport, things like feeding have become more of a barrier towards them getting access to care. And so as a foundation, that is where we step in to try and bridge that gap to ensure that every child has equitable access in terms of the psychosocial support elements. But also what we do is that we create awareness about childhood cancers. The biggest challenge that Uganda is facing at the moment is that cancer diagnosis is late, and as a result, survival is often limited because the doctors are basically fighting to save life rather than trying to save life or giving that care towards end of life, and as such, we lose many lives because of the late diagnosis. So as a foundation, we focused pretty much on how do we create awareness, how do we sensitize the community about cancer in children, and we met a little bit of challenge with working with adults in the initial stages because very many are adamant to change, and often they will say, "Let the cancer come and get me if it gets me." And so we had to change our approach and look at how do we then address the issue of the next generation. And that is where we started working with the 3C program, that is Children Caring About Cancer, a program that we implement in high schools, working deliberately with the youth. And we have seen that working with the youth has also helped us to actually approach the elders because these children take the knowledge that they learn from our project or our programs, and they take the knowledge that they learn from us and take it back to their communities, to their parents and their siblings. But we've also seen that because of the knowledge that we've been able to give this youth in the schools that the program has been running, they have identified some of their colleagues who had cancer, and as a result, some of the colleagues were gotten late, some of the colleagues were identified early, and so treatment was given to them a little bit early. And so we are looking at how do we prepare the next generation to be knowledgeable, borrowing pretty much on the basis that HIV/AIDS had in Uganda, because in Uganda HIV/AIDS was pretty much handled well because this information of HIV/AIDS was trickled down to the lowest level of education in the country. And as such, we realized that we grew up as young people knowing if you got cut, and share the cut with someone who is HIV positive, you'll also get HIV. If you had unprotected sex, you'll get HIV. And so we became scared of having sex, literally. And there was a good response. And young people were able really to take on the information. And so that is the leaf that we borrowed, and it's working quite well in Uganda at the moment. And luckily, we don't have to be the ones that are training. It is often the educate these young people. But we've also seen that with these young people, sorry, I think my internet has a bit of a challenge, but because of the education that we provide to these young people, they have become the key element when it comes to survivors' reintegration back into the community. One of the things that I faced when I became a survivor is that many of the friends at school did not really much want to associate with me, and as such a story because I was afraid that I would be stigmatized. But in the schools where we have been able to train the young people about cancer, they have been the ones that try to reintegrate their colleagues back into the school, help them to ensure that they feel comfortable in schools and in the communities that they are in, which I find very fundamental when we're talking about survivorship, because then we have a clear pathway that we are treating, we are also eliminating the element of stigma, which often leads to the aspect of depression. And I think that is very critical. So I hope I've not spent much of my time, but when we talk about also how do we utilize survivors, I happen to have been part of a fellowship really recently, that is the NCDI Poverty Advocacy Fellowship. And one of the things that we've realized is that how do we need to figure out a way how we can involve survivors into all the policies that we make, because these are people that will feed into the experience-based aspect of the journey that is cancer treatment. They know what they have gone through, and they know what their predecessors will have to go through. And so it's a question of how do we integrate survivors into advocacy, advocacy, how do we integrate them into policy making, how do we have them become really a core element of the skeleton of whatever we're trying to do in terms of cancer management and care. So I think I'll leave it at that for now, because I know Udi will have a couple of questions for me later. Thank you.
Thank you so much, Moses. And for sure, I do have a couple of questions for you. Our final speaker is Gertrude Nakigude. Gertrude, over to you. Thank you.
Thank you very much, Udi, for the invitation and introduction. And I'm Gertrude. Good day. Breast cancer survivor for 20 years, and I had an organization
Sorry, Gertrude, we're having some trouble with your audio, your connectivity. You may want to try turning your video off. Oh no, it looks like we've lost her. Hopefully she will join back again, but Udi, Gertrude is
Okay.
off.
Thank you very much. Thank you to all our panelists for these insights and this sharing, and really raring to go with questions, because we shall be opening the floor to questions and answers. We have, as I had said earlier, about 55 minutes. But before we go there, I'd just like to remind all of us what the theme is for today's meeting, as well as the objectives. Theme is integration of survivorship at the policy level in Africa. And our objectives: one, to discuss current efforts in survivorship in Africa from a personal, community, clinical, research, and policy perspective. Two, to outline the importance of defining and deliberately incorporating survivorship in policy and practice development and implementation. And number three, to deliberate on ways to ensure that ministries of health work with and incorporate inputs of all stakeholders as they integrate survivorship into their national cancer control plans. As we now open the floor to questions, allow me to start as we think about questions, or maybe we already have questions, please post in the chat. One of the things that struck me as our panelists were speaking, was the fact that whilst we talked about patients, about survivors, the person who has actually been diagnosed with the disease, we have in Zambia, it's a term called co-survivors. I am the caregiver, so I have also survived in my own right. And very often, the co-survivor or the primary caregiver outlives the patient or the survivor. That's one thing that I noticed. We wasn't much emphasis on that. And then secondly, the term itself, survivorship, it kind of gives the impression, if that's the word, that I am going to live, I'm going to survive it. But as we know currently, the majority of cancer patients do not live beyond 5 years. And there are very often incidences when patients are diagnosed when the disease is terminal. So is even the word survivorship the most appropriate word to use? Questions to the panel and to the rest of us. And specific a question, and it's not to anybody in particular, any of the panelists, but just anyone of you can come in. But my question to get us going is, why is it important to define survivorship in policy documents and guidelines? And how should that definition be generated? I'll repeat the question. Why is it important to define survivorship in policy documents and guidelines? And how should that definition be generated? Any of the panelists, you are free to answer my question, if you may. Thank you. Why is it important to define survivorship in policy documents and guidelines? And how should that definition be generated? Thank you.
I probably will oh, sorry, Miriam, you want to check, go on?
Go ahead. Go ahead. I'll just.
Okay, cool. I just mention a bit and as well. So the first part is why, and I think we all agree in terms that policy documents or policy give priority of how allocated where budgets go in terms of what would be focused on in terms of the entire health plan. So I think it's very important that survivorship is clearly defined in the policy, because that then will make sure that it's given the appropriate attention in terms of budget, in terms of priorities, in terms of resources. And that's really, it's a very first step. And how should that be done? I think that conducting a needs assessment, to inform what are the survivorship needs for that specific context should be the first step. I tell you that because, as I told you earlier, I work with cancer patients from two completely different contexts. The needs that I found from our survivors in Nairobi and the needs that I find with the survivors in this where I am currently are way different, I would say. While there are cross-cutting needs in terms of like quality of life, like well-being, like supports, the very specific needs are very different and they are very contextual based. But also in terms of the gap, that what do majority of survivors what kind of needs do the majority have? Is it just information needs? Like, is a case here, or is it just perhaps mental health conditions that not even noticed or recognized or diagnosed? For instance, when we did the study in Kenya back then, 78% of all the patients that we had, which is like 300 of them, undergoing cancer for treatment for cancer, 70% of them met at least, the diagnostic criteria for anxiety or depression. And then when we ask them whether anyone has ever talked to them about, their psychological well-being in terms of, distress, they say no. And they said, if at all I got someone to talk to me about what the cancer is making me feel, other than just coming here every day for chemotherapy, that would really be helpful. So you realize it's very important that we conduct a needs assessment. I know, like in Ireland, just 2018 conducted a needs assessment, and this needs assessment can be continually. Like every time we are trying to either renew the plan, then we do a needs assessment, or what perhaps Miriam referred a situation analysis, including all the stakeholders involved, survivors, caregivers, policymakers, everyone. And we kind of get what's the situation like, and that kind of informs the plan. So that's what I think, but definitely get to hear from.
And maybe if I can chime in a little bit, because Isaiah's raised quite a number of important concerns really around, anxiety and the distress that exists. But Udi, you also mentioned quite a number of gems sort of in your staging of the conversation. And I'm going to go a little African a bit, but I mean, the question is, why should it be in our narratives? I mean, why should it be why should we have it as part of a control plan? And we say in the African context, names are powerful. Yeah. If we don't, in fact, if you're not named, it's you don't exist in that community. And so the first step towards defining survivorship is really getting it on paper that yes, survivorship occurs, because I think it's also important in terms of the mindset and shifting narratives around cancers, because part of the thinking is that why are we even bothering with survivorship if we're all going to die anyway? You know what I mean? We're like, well, we're saying that, due to concerted efforts, we are starting to see a change. And unless we acknowledge that change, then it doesn't exist. We're always saying, well, we can't, pour money into this because of 1, 2, 3. And as we're seeing, there are quite a number of different aspects that go through the survivorship experience. And I think you sort of touched on one of these, Udi, around, there's an emerging concept around time toxicity, and looking at also from the caregiver perspective, the patient perspective, about time spent just trying to access care. Sometimes the hidden costs of treatment. It's not just getting the chemotherapy. It's, I can get the chemo, but I have to choose between chemo and my next meal. And so that kind of balance, or I have to figure out how do I get to the hospital. We've had patients who come in and, told you have to live, you have to stay in the urban area for a month to get your radiotherapy, and they're like, it's fine, I don't need to be here. And so really starting to unpack those aspects of survivorship that actually go into the whole experience of the patient, I think is important. And unless we start to put those into the policies and say, hey, this is what patients are going through, and these are what, on paper, yes, you've given us we've tried to decentralize care, and you've brought the radiotherapy machine closer to us, but in reality, we can't afford to go to the radiotherapy machine because we don't have enough to eat, or so all those different aspects. And that starts with actually having that integrated into the policy and continuum of care. The how, if I can maybe touch on that briefly, is it really lends itself to co-creation. I mean, this is not things where we're coming down from the mountain and deciding on what it is we think best. It's really looking at what are patients going through, what are caregivers going through, what are healthcare providers going through, what are policymakers going through, but looking at more of, yes, we can talk about the challenges for us to do better. And I think it was Moses who gave an excellent example about how do we perhaps start to leverage existing networks, say around HIV. How do we then, rather than looking at it as a health, just purely health concern, start to look at it as a equity concern, and rather than looking at it as, sort of looking at just cancer, looking at it as how do we integrate wellness into this? How do we bring and because we do need to think about multi-sectoral approaches to this, how do we bring the finance guys on board? How do we bring the education people on board, like Moses is doing, to sort of talk to people around these concerns? And how do we normalize, for want of a better word, having cancer? And so hopefully the idea is that with this co-creation and regular discussion and iteration, we shouldn't have to talk about reintegration of the individual, because that individual should never have left the community in the first place had we put in a good survivorship policy. And that's really why and the how I think that we do need to consider, especially when approaching some of these concerns. Thanks.
I'll add one more thing to it, sort of the macro level. I think our analysis of these NCCPs showed what happens if we don't define survivorship. So of the 21 plans, only one of them actually defined it. So shout out to Malawi. And I think, that doesn't necessarily mean that they don't include good survivorship strategies. But I do think one of the impacts of that is, like I mentioned, the majority of all those strategies were limited to palliative care. And I think defining survivorship expands that definition and would hopefully then expand what's covered in the plans. And like we've all talked about, maybe when they wrote these plans 5 or 6 years ago, that was a little bit more understandable, but we're making so much progress that I think in the next iterations of the plans, it'll be really important to expand that definition.
I think for us, one of the things that I've learned while sharing with Dr. Jace and Dr. Geriga here in Uganda is that for a survivor, we're not limiting the definition of a survivor to just someone who has beaten cancer. One of the things that we have said is that even the person who has just gotten diagnosed, that person is a survivor, because they are walking through a journey that not many people get to walk, and they are the warriors that get to walk that journey. And so the doctors here insist that even from the stage of diagnosis, that person becomes a survivor. From then, if they beat the cancer, of course, that is now where my questions with them were, now that they have beaten the cancer, what terminology do we use? We still call them survivors, the same way we're calling the person that has gotten diagnosed. But all in all, I agree with Miriam and Isaiah that the whys give us a basis for how do we now plan for them. Because here in Uganda, one of the things that we've done in the National Cancer Control Plan that we are waiting for Parliament to pass is that we have found a way of involving survivors in everything, be it in the adult section, be it in the pediatric section, because we appreciate the contributions that each and every one will make towards improved access, but also improved retention to care. So I would say that's for me the why we need the survivors to help us with strategizing on how do we improve on access to care, but also improve on retention for care and treatment, because that has been a big element in Africa, be it adults, and it's getting really worse with adults, because many times adults will tell you, I think I've lived my life, and then they abandon treatment. It's not the same with children. Children, if the mother says, take the medicine, we'll take the medicine. Adults, you've had a bit of an opportunity to live life, and so you know what hardships are and what challenges are. So when the cancer comes and the chemotherapies are hard as they are, you want to give in easily. So yeah.
Hi, sorry. I think it's really important to define survivorship. I see a lot of survivors when they are still on maintenance treatment, they feel they are not survivors. So we need to clearly define what we mean by survivors. Do we need those who have completed treatment? Do we need, can we categorize those who are living?
Gertrude, I think it will help if you switched off your video. You are breaking up. Thank you. Okay, Gertrude seems to be frozen as she,
Maybe as Gertrude is getting back,
yeah,
maybe
as
just
she
to,
gets,
oh, I was going to chime in briefly around the definition of survivorship, and I don't know if you can hear me okay.
mhm. Yes.
No, I was just saying, sometimes it is important to define, but I sort of have a different perspective around it, in the sense that sometimes we get hung up on, is it at diagnosis? Is it when you've completed 1 year? Is it 5 years? Is it 2 years? And I think sometimes maybe we need to take a step back and look at what are the key issues, because the key issues, whether you're at diagnosis, and it's looking at what are the key issues at each stage of the cancer journey, for instance. If you started, and there's some universal sort of services that are required that are germane to the entire continuum. And so you find that at diagnosis, maybe there's a need for, psychosocial counseling. Maybe as you go through the maintenance phase, there's a lot of, maybe you might need counseling, but around different concerns. And so I would say perhaps rather than hanging our hats on a temporal sort of definition, looking at it more at what are the key factors or key strategies that one would need along each part of the journey, and how do we incorporate those services into each part of wherever they are on the care continuum. And so that's how I would sort of think about the approach to definition. Thanks.
Thanks very much, Dr. Miriam. We have a question from Christine Schroeder. She says, how can we find out who the representatives are for policy development in individual countries? There are many of us who are creating interventions, evaluating costs, creating programs for survivorship care with great effect. How do we get that information to the people working on NCCP or policy so they have the data to inform recommendations? Any of the panelists to take that one?
I don't want to keep chiming in. I'm trying to give people an opportunity, but well, okay. I'll give it a go. I think there's a couple of ways that one could perhaps tap into this, because one is taking advantage of the regional and continental bodies that exist that are pulling together care professionals along the continuum. So of course, this is a plug-in for the African Organization for Research and Training, but that's one of the avenues that one could look at least for the African context. In terms of looking broader, one would also consider the ICCP, which tries to coordinate quite a number of national cancer control programs. And so they may also have access to quite a number of individuals who are working in the National Cancer Control Program space. And so there are definitely ways of ensuring that you're able to engage with policymakers, but it's pretty much figuring out who's doing work within the National Cancer Control Programs and how you can perhaps link with them locally or regionally. to see how you can sort of impact care in the region that you're working. But so I would say the first step would be taking advantage of your local oncology societies and things, because most of them, at least the ones in Africa, tend to have a very heterogeneous group of people, and you'll always find at least one or two people working in the cancer policy space. Again, taking also advantage of the CSOs as well can sometimes give you access to direct at least one or two individuals in policy. So those are just some of the ideas that one might use in order to engage or at least get a greater audience with policymakers. Thanks.
Thank you very much, Dr. Miriam.
sorry.
Caroline, there is a comment by Caroline in the chat. She says, the American Cancer Society uses the term cancer survivor to refer to anyone who has ever been diagnosed with cancer, no matter where they are in the course of their disease. So from time of diagnosis till end of life.
Udi, probably
Thanks very
just,
much for
sorry.
that. Go ahead,
No,
Isaiah.
I just wanted to add to what Miriam said, but now from the other side, like from top and bottom, you know. So I think also the National Cancer Control programs, or what is it, policymakers in this context, needs to be more visible in the communities, or in the, like, working with all the stakeholders. And that's why it's very important that the National Cancer Control program, or in some countries, the National Cancer Institutes or policy in the individual countries, because even got Christine's question was, there are so many of people working in the community in different projects, trying different interventions, but then they are not aware who the policymakers in that country are and how that data could be useful, maybe to be scaled up or to be, used to inform these kind of policies. So I think the National Cancer Control plans, or the Ministry of Health or Department of Health in this context, need to be more visible. And how to be visible is like to make sure that their services are seen and they are working with those stakeholders. So kind of doing a mapping of all the people, all the stakeholders working different, in the entire country, like getting to understand what is it they are doing. And because, yeah, just like for mental health, if I do that correlation, many years back, there were so many different groups trying different interventions for mental health, like in Kenya. And it was so disintegrated in the sense that it was maybe in just one community or one county. But then when the government realized that, then it didn't, kind of brought together like a task force to try and see what is it that is happening in the entire country in terms of mental health. And a lot of very useful information, very useful projects were, discovered as a result of that. So I think from a top-bottom kind of approach, the ministries of health or departments of health or the National Cancer Control programs and policymakers need to be more in touch with all the stakeholders, including the survivors, the caregivers, the CSOs, the NGOs, and all other players working the space.
Thank you very much, Isaiah. We have a comment in the chat. Edward says, just thinking aloud, can the survivorship definition be narrowed down depending on the type of cancer, say leukemia against other solid tumors? Otherwise, attaching a time frame to the definition would be more ideal. A question I would like to pose to the panel and to everybody else is, why do we appear to be having great difficulty in actually defining survivorship or not defining survivorship? I am not sure why that is. And maybe, as Edwards said, it's because it's such a complex disease, affecting people differently, from the patients to survivors to the caregivers. But having said that, taking a leaf from the HIV space, what lessons can we learn? Because they rallied together and made a difference. I mean, there was a global fund for HIV, a lot of programs up to now are still running. But with the cancer, in terms of cancer, we seem just amongst ourselves not to really have gotten grips, starting with the definition itself. We're doing a lot of great work, but it seems to be fragmented. And then adding to that, talked about the importance of engaging with policymakers. As cancer survivors, advocates, I believe we need to be more visible, to really make a loud noise and to shout on top of the highest mountain, like the way the HIV movement did. I think there are a lot of lessons. But again, what I wonder, maybe we have answers, hopefully we do. Why, again, is it that those of us in the cancer space are finding it difficult to gain traction, involving policymakers, in order to, not only policymakers, but just even in advocacy? Is it the stigma that is attached to it? Is it lack of resources? Or what are the key barriers that are holding us back, holding us back for us to make noise and to have greater impact than we are having at the moment?
One, I want to say that, first of all, in the previous years, between, I would say, the 90s to the late 2000s, the major focus for most of the countries was on how do you improve on care. I'll give an example for Uganda. Dr. Jackson Orem, one of his major focuses was on how do we have infrastructure that is able to provide healthcare to every single Ugandan that comes to the Uganda Cancer Institute. And now that journey began in the early 2010s to the late to now the early 2020s, the focus has now shifted, is now starting to shift to how do we get the government to start giving us more budget allocation in terms of cancer care. And so I think that in the previous years, one, we're dealing with a big population of doctors who were focusing on treating. But now we're also dealing with many doctors who are saying, okay, we are doing a lot of treating, but now how do we now create an extra ecosystem that is able to embody everyone, looking at survivors and the like? And so we are now treatment to an era of how do we make access to care equitable and accessible to everyone around the app. If it is, say, in Kenya, how does it get to someone in Naivasha, someone in Turkana? If it's in Uganda, how do we get to Karamoja? How do we get to Mbarara? The like of things. And here I'm not about distances, about 800 kilometers away from where the centralized specialized treatment care is. And as such, because now that we have gotten to the stage in cancer where we are now looking at how do we advocate, we are now starting to understand advocacy. I think one of the biggest challenges that we are now facing is not many of the advocates that we have are empowered enough to be able to actually speak about some of these things, some of the journeys that they're facing. And I think that it's now imperative for us as those who are knowledgeable, those who have the resources or the capacity to train up and rack up a community of strong advocates. Because one of the things that I have come to observe is that the reason as to why not many African countries have been able to look at NCDs or look at cancer as really strong diseases that are attacking people, that are taking a big number of people, is because the strength of advocacy has been weak. You get what I mean? And as such, it is now the onus is on us now to strengthen our advocacy capacity, because that is where our silent weapon is. You have strong advocacies. These are people who are going to speak to the different policymakers, different budgetary allocating individuals, people who are able to make key decisions that will favor or that will be in line with what your national cancer control plans are. So for me, it's about how strong the advocacy capacities are in the given countries, especially in Africa.
Thank you very much, Moses. Gertrude has a comment, and she says, advocates need to be focused and organized on what we want to be addressed. Is it research, post-care, economic empowerment, and so on? So this is something food for thought. Caroline says, I don't think people who experienced the cancer diagnosis were involved in the development of the term survivorship. Here, Carol. Right. Okay. Thank you very much for all your contributions. Gertrude, we haven't heard from you as a speaker. Are you able to give us, are you able to speak now? How is your network?
Thank you so much, Udi. My network is very bad. I moved away from my office. There was a bit of noise. So where I am is very unstable. When I try to speak, I get disconnected.
Okay.
Sorry, I've missed most of the conversations, but I'm grateful to be part of this conversation. And it's really important for us to have a definition of survivorship that speaks to our context as Africa, because survivorship, when you're still on treatment, it doesn't make sense to a patient. But also, we need also to look at things that we feel we want to focus on. There are lots of gaps. Clinically, as survivors, we don't even have clinics in hospitals where we go. There are no special clinics for survivors, and our needs as survivors are totally different from the needs of the patients that are on routine care. So we need to amplify our voices, but also in the charter, we need to have guidelines, survivorship guidelines, that maybe will guide those who want to advocate, and then maybe the care. So thank you so much. I say warning that my internet is unstable, but I keep.
Thank you very much, Gertrude. Gertrude touched on survivorship care, and Elise, I believe you did so as well. Could you just share with us some examples of a survivorship care plan? Elise?
Yeah. So, and I think we're talking about like the actual individual survivorship care plans and not like a country plan, right? So this is, of course, another area where there's a lot of different definitions and recommendations. And I think, so for example, like the US CDC has actually like published a definition of a survivorship care plan and sort of what should be included. And that is very based on the US context. So there's a lot of things in there that talk about like what should and shouldn't be covered by insurance, for example, and sort of different like legal, financial, and emotional needs of the patient. So I think there's some room for context-specific definitions in here as well. And at least based on our analysis, there were only 4 national cancer control plans that even sort of mentioned the provision of a specific survivorship care plan. And so that would be a good place to start, is at least in those NCCPs, sort of define what should be included in a country's care plan. Even then, though, I think what we've talked about, every person's experience with cancer is so different. And even every individual diagnosis, like you've said, being diagnosed with cancer at 23 versus 49, your needs in that plan are so different. And so I think while sort of having standard criteria for inclusion in a survivorship care plan is important as a starting point, it really does need to be individualized and go well beyond that sort of national planning level.
Thank you very much, Elise. Is there anyone who would like to add to what Elisa said? We're talking about survivorship care plans. Does anyone have any other examples, for example?
Sure.
In our African countries, is there any country that has, in Africa, has a survivorship care plan embedded in policy or some document, official document? Thank you.
I'm just going to maybe comment on my just on the process around the NCCN and sort of talking to colleagues on the continent. Again, there is a recommendation for sort of customizing the care plan, but that hasn't necessarily, translated into care. And maybe one of the challenges has been really trying to contextualize that to our context. To our settings where we think that there's definitely most African countries have this sort of tiered level of referrals. So you go from maybe dispensary, you go to the community hospital, go to the district, go to the province and stuff. And what we realize is that really our cancer centers are sometimes overwhelmed. And the challenge is we've not really built in that bi-directional sort of flow and things, because one of the things discussing with colleagues is for a care plan, say from a quote unquote survivorship aspect, they don't necessarily need to be coming into the major center every 3 months. Whereas if they had a primary care provider who was educated and empowered and would be able to be part of their continuum, they would be able to get their care closer to the setting. So that hasn't really percolated, but I think those are some of the aspects that we do need to look at. How do we sort of unclutter the major cancer centers and leave them to the business of treatments, but then really looking more at community engagement and empowerment at the community and grassroots level that actually facilitates continuing care closer to the patients and in the environments that are familiar to them. And so whereas we might not have as many care plans percolating, those are the things that we do need to think about critically in terms of educating our primary healthcare providers and what are the roles and responsibilities that we can actually assign to these particular cadres and how they can help with enhancing the entire continuum of care. Thanks.
Dr. Miriam, thank you very much for that. And you are so right. We do not utilize the primary healthcare providers as much as we should in this conversation, because I see my GP far more often than my oncologist. So what I'm hearing you saying is the importance of collaboration with different stakeholders. That is very, very key. And the usual healthcare providers that we know of, and then there's those different aspects of healing, from the spiritual, from the mental, from nutrition. The traditional healers, by the way, we shouldn't leave them out of the equation. So it's very important we bring all these people to the table and have these conversations. And I know this is what we say ever so often, but moving to that next step seems to be a challenge, but hopefully we will get there. There is just a quick comment by Elo. He says, sorry, I don't know if it's he or she, excuse me. I know the NCCP in Kenya had attempted to develop guidelines on survivorship. Not sure where that ended up though. Okay, at least an attempt was made, so maybe it's picking up from there. My dear friend Mishka has telling me ever so nicely that you need time to wrap up. And I'd like to take this opportunity to thank all of you for your participation. It's been an honor and a privilege to be your moderator today. We have, in my view, literally just scratched the surface, and much more needs to be said, more importantly, to be done. And I hope this will encourage us to look at the whole role of survivorship more critically. And some of us are cancer survivors. So, really, we should be in the forefront. And at this point, I don't want to go, but I have to go. I would like to say again, thank you very much to all of you for your attention and for being, great members of this meeting. Thank you very much. Over to you, Mishka.
Thank you, Udi, and thank you, everyone. This has been fantastic. I'm actually going to pass to Charles so that he can wrap up our session and get us ready for the new year. And thank you for a fantastic way to end 2022 together. Over to you, Charles.
Thank you. Thank you so much, Mishka. Thank you, Udi, and the wonderful panel of speakers for today. I think we can all agree that we've all learned a thing or two about cancer survivorship. So I'm going to be sharing the recording for the session maybe by tomorrow, so that you're able to look at that over the holidays. Then we are going to continue with our sessions next year. Our next one will be on January 19th. And we are going to be looking at a topic on service delivery, and specifically we are going to be looking at the issue of patient navigation, how we can use patient navigation to improve service delivery for improved cancer outcomes. So we hope that you will be able to join us then. So thank you very much, and we wish you happy holidays and see you in January. Thank you.
Thank you.
Bye, everybody.
Bye-bye.
Thank you.
Ciao.
Thanks everyone. Happy holidays and stay safe.
Happy holidays.